So if you have anybody that was really disappointed that they weren't able to attend because we filled up so fast, let them know that this is being recorded and will be posted to our website. Additionally, I'm going to go ahead and I'm going to put everybody on mute. Feel free at any time to use the chat box if you have any questions, and we will allow time for some discussion at the end of the webinar. And if you prefer to ask your question, you can raise your hand and we can unmute you, or you can write us a note and let us know in the chat box. Whatever works best for you is fine with us, okay? So I'm going to go ahead and mute everybody now, and we'll get started. So thank you so much for joining Noah and I this morning. I'm Andrea Crook. I know it's a little confusing when it says Danielle Zavala is hosting it, but we are just using her account for this platform. I want to thank Noah very much because this has been a labor of love for him. He's very passionate about the social determinants of health and created this really meaningful presentation for us today. So with that being said, I'm going to give it over to Noah to say a few words, and then we'll dive right in.
Good morning, everybody. So I just wanted to start with a kind of a prelude, and we hear the social determinants of health, and it was brought up as a learning webinar because it's kind of a buzzword at the moment. So I just kind of want to give a brief introduction. Social determinants of health are important to investigate because when we see higher rates of chronic physical or mental illness among poor people and minorities, then we want to know what is the cause. Today, we want to be sure and state that people are complex and there are many variables to illnesses. So we are not saying that one social determinant of health causes illness, but we do need to investigate statistics that show overrepresentation in specific demographics and how one, some, many, or all social determinants of health play a role in human health in order to develop healthier, happier, and longer lives for everyone in thriving communities. As most things in this world, there are no absolutes, and we are speaking in generalities, probabilities, and likelihoods about populations that and how they overlap most logically or in an interpretation.
Thank you, Noah. All right, so just a brief overview. So a little bit about Access. We are a program of Cal Voices. For those of you that are unaware, we are formerly known as NorCal MHA. We've been doing statewide advocacy work for well over a decade in multiple programs. So we needed a name that represented us better, and Cal Voices it is. So Access is a consumer-led stakeholder advocacy program funded by the California Mental Health Services Act, otherwise known as Prop 63, and the Mental Health Services Oversight and Accountability Commission. So a little bit about Cal Voices, formerly known as NorCal MHA. We were founded in 1946, so we are over 70 years young, and we are the oldest continuously operated consumer advocacy agency in California, and quite proud of that. We're also a peer-run organization, and we specifically hire individuals with lived experience throughout all of our programs. So Access can be a mouthful, but if you want to say our full name, it's Advancing Client and Community Empowerment Through Sustainable Solutions. So if that's too much, feel free to call us Access for short. So our values, as well as our annual themes and annual research topics, are advocacy, recovery, and peer support. We want to ensure meaningful stakeholder participation is happening at every level throughout the public mental health system, as well as active solicitation of community feedback. And it's really ensuring that this programs and services and systems are client driven. We're advocating for always expanded opportunities for meaningful involvement, as well as inclusion at all levels in policy development, program planning, and implementations of services delivery oversight, as well as administration. We really are focusing on the infusion of recovery principles in all aspects of service delivery, and encouraging ongoing recovery-based training and support for mental health professionals, as well as all community stakeholders. And we are always continually advocating that we are tracking meaningful recovery outcomes and reporting on our findings, and have a full analysis of recovery outcomes in all mental health programs. If we are not measuring meaningful recovery outcomes, then we're missing an opportunity to create new programs or expand existing programs that really have meaningful outcomes. Additionally, we are always advocating for fidelity to the evidence-based model of peer support and peer providers, as well as the incorporation and expansion in all mental health programs. So we want to see peers throughout the entire system at all levels, as well as living wages, ongoing professional development, and opportunities for advancement.
So the social determinants of health, as we mentioned, is kind of a buzzword, and they are the social factors that increase or decrease health or severity of an illness. For most of the history of medicine, we have considered physiological factors that make up someone's health condition. For example, kidney stones are not social, but can be related to unbalanced nutrition. And a heart arrhythmia is physiological, but could be related to a prenatal care or childhood development, dependent on adult mother's living situation. Additionally, asthma is caused by worse air quality, which is related to pollution and climate change, and most directly impacts poor and minority neighborhoods. So, social determinants of health is an academic term, but today we're going to think very simply and hopefully very logically. So for example, the first social determinants of health is poverty. And if you think about it, it really is expensive to be poor because with a smaller income, every expense absorbs a higher proportion of your income compared to those with more affluency or richer communities. This means that housing and food are more expensive proportionately and eliminate unnecessary, quote unquote, unnecessary expenses like preventative health care, checkups, and routines. It's also stressful being economically unstable at any socioeconomic level, but especially when basic needs are at risk. So we're looking at systemic factors that are often things that are out of an individual's control, but have a huge impact on their lives.
I do want to say I forgot to mention that we have attached for your convenience a copy of today's PowerPoint presentation. So feel free to download it after today's training or during if you like.
Today we're going to go over a review of the social determinants of health, how social determinants of health relate to chronic stress, how social determinants of health relate to adverse childhood experiences, and how social determinants of health correlate to health disparities across California and in some cases some national numbers as well. So we'll start with part one, which is the overview of social determinants of health. So we want you to consider and think about this webinar and how these social determinants of health have affected, how these social factors have impacted your lifestyle and your health. All the social determinants of health are correlated and interconnected. The 5 categories of determinants are economic stability, education, social and community context, neighborhood and built environment, and then of course health and healthcare, which includes access. Not us, but access to healthcare. So one of the things that the social determinants of health is kind of built on, or that you need to keep in mind, is this theory called Maslow's hierarchy of needs. So on the visual, you can see that it kind of goes from basic needs to more esoteric needs, I guess. And so we want to look at how social determinants of health affect different levels and all in various ways. So they impact health in equal and coordinated ways as well. So if you're looking at how we have access to quality air, quality water, food, shelter, sleep, you also want to think about personal security in a neighborhood or employment status or how they have resources, usually economic, and how they have access to health or housing in general. So we'll start with economic stability. That starts with poverty, employment, and food security. Food security and housing stability that make up economic stability. So we mentioned poverty just a moment ago. And again, we want to think really basically in how these impact people and their lives. So logically, no one chooses to struggle and to be poor. You're born into poverty and into the social conditions that create it. So when we're looking at poverty as a social determinants of health, we want to point out that there is an overrepresentation of low-income people with health needs, and that's also because of unaffordable health care that perpetuates health disparities. And then additionally, more crime is enforced upon poor people, and incarceration is another social determinants of health and is a cause and effect of adverse childhood experiences. So when we're talking about more crime being enforced upon poor people, that is another academic term called the criminalization of poverty. It includes laws that prohibit panhandling for homeless folk, or different criminal charges for example, crack cocaine, which is more frequent in poor communities, versus powder cocaine, which is more prominent in rich communities. So I use this example because it's the same drug, but different criminal charges and enforcement are placed upon various, whether it's crack cocaine or powder cocaine. And then basically, we also want to reinforce that it's kind of dangerous to be poor because there is higher crime, and it's more enforced upon poor people because nationally, the average income of a male inmate was less than $20,000 in the United States. And this statistic indicates that most inmates made less than California's minimum wage. So there's numbers to back up the idea of criminalization of poverty. So when we're looking at employment, we also want to consider the populations that we're working with or that we understand. And if we're thinking about California consumer and client populations, it's kind of unfortunate, but there's 90% of California consumer population is unemployed. And when you think about daily purpose as which is often employment is a principle of recovery, then you're also looking at how unemployment affects their health. Additionally, unemployment, low wages, and low education are why most people are poor and are perpetuated into cycles of poverty. And we also want to note that the American lifestyle is really expensive, and that the same minimum costs are a minimum for rich people as it is for poor people. And again, so higher expenses take a higher proportion of your income if you're a poor person. So, and then when we get to food security and housing stability, we want to look again at Maslow's hierarchy of needs, which was the base was food, clean water, and shelter. So when we think about not having food security and not having housing stability, that kind of creates chronic stress when you're thinking about where your next meal or where your next bed will be. And it is an example of how social determinants of health are correlated and interconnected, because extremely low income people in poverty are at the greatest risk of homelessness as well. So that's employment, poverty, and housing stability that all create this risk of homelessness. Next slide. So education is kind of California's go-to as far as how to promote social mobility and how to create opportunity in the state. This is because education is correlated to financial success over a lifetime. with high school graduation, people with high school degrees are less at risk of homelessness and have lower rates of unemployment. Additionally, even enrollment in higher education, being university or community college, shows that people with at least some higher education earn statistically significantly more over a lifetime. So I believe there's a picture on the next slide. So this graph is from the US Bureau of Labor Statistics. The higher degree that a person earns, the less likely that they are to be unemployed, even though they could probably afford some time unemployed. And then also the people most at risk of homelessness are extremely low income individuals and families. And serious mental illness and substance use disorder on the streets is more likely caused by poverty and homelessness, not the other way around. So we're looking at things that are creating chronic conditions rather than things that are caused by chronic conditions. Go ahead. Additionally, with education and why it's so important is because we're looking at language and literacy. Language and literacy are a part of the success markers of a good education. It takes good education to be literate enough to navigate higher education grant programs and to be able to get those higher degrees. And then also, we want to be sure to recognize that cultural competency in healthcare and being able to access a medical system that's primarily in English or unavailable in other alternative languages is a barrier for ways to get care or to establish care or, again, preventative care and those things that lead up or that can, if avoided, can cause chronic conditions. And then early childhood education and development is a big one because the return on investment on childhood education increases with earlier developmental stages of childhood. So you might have heard Governor Newsom mention that he wants to focus on early childhood care and prenatal care and make it more available for low-income individuals. And this is because the graph below was designed by a Nobel laureate in economics, James Heckman, and it illustrates that the greatest return on investment is in early childhood education and prenatal care in the early stages of life. So social context or social and community context is kind of my favorite as a sociologist background in my degrees, because when I think about social cohesion, I always think of like kind of the neighborhood that I grew up in, how easy it was to go ask your neighbor for anything that you might need, or to bug somebody, or to walk comfortably down the streets, or to not feel at risk or in any type of any barriers between community members. So an example of social cohesion, which might be kind of an abstract term, is whether you can or do you ask your neighbor for a cup of sugar if you need it. You remember those old-timey movies that would say like, oh, just go ask your neighbor for a cup of sugar. Anyway, that's what I think of. And so there's also civic participation, which is the voting and other civic engagements show a commitment to other members of the community and usually gain political representation, which allows greater participation between community members and a commitment among them so that you can identify with your neighbors and how you relate between different community groups. And one of the things that we want to look at is that also middle to high income white voters are the most engaged because of a legacy of discrimination. So we're going to look at historical and institutional discrimination, which is just below in the discrimination category, and how this leads to minority communities having higher health disparities and what it means as far as the legacy of housing discrimination, voting discrimination, and the institutional factors that have been present for a very long time. And then we're also talking about incarceration. There's an overrepresentation of Black and brown people in California's jails and prisons. They're usually family members of families affected by trauma, crime, violence, poverty, or discrimination, or all of them. A majority of California inmates had trauma in their childhood when they were screened and have higher rates of serious mental illness. So we're looking at those that have had ACEs before it was a term, and those that now have developed serious mental illness in institutions or before they got into institutions, and why those things are causing issues for them now. Again, so we're still looking at kind of, so this is the more physical element of a neighborhood and a built environment. What are the resources that are available in a community? So we're looking at access to healthy foods. Related to poverty, there are food deserts, which are areas without grocery stores that are more common in low-income communities. There's also usually more liquor stores, fast food, and not fresh food in low-income communities, according to the density of their placement. So, and then additionally, the quality of housing. This is one of the institutional factors that we want to recognize as far as the leading up to disparities in current healthcare industries. Redlining is a housing policy that was instituted in the past to segregate communities by race, and it has lasting effects on quality of housing, development of ghettos, percentage of home ownership, and concentration of minority communities, food deserts, and low achieving schools. So there was a story that actually came out earlier, maybe in December, that was about lead paint exposure. And they said, is it discriminatory that more Black and brown renters, usually in old or poorly maintained housing, have higher exposure to lead paint than white renters or homeowners because they're in various housing because of communities that they're expressly or implicitly excluded from, or not excluded from, but that were excluded from, and how they were maintained. So there's additionally crime and violence. Do you feel safe in your neighborhood? Again, one of those things, can you walk down your street? Can you talk to your neighbor? Can you ask them for anything? And if we think fairly logically, poverty is perpetuated by low wages that creates a need for alternative incomes and income sources that kind of lead towards crime, and how to use it, or how to use it to your advantage. And then again, we're talking about over policing of poorer communities. So as a note, we want to recognize that overall crime is down and violent crime is down, but that's most likely contributed to higher education in communities over the last 50 to 60 years now. But we also want to recognize structural inequality is more present, and that means that there's proportionally more petty crime, property crime, and illicit drug use and distribution. Trying to make that dollar that you aren't able to earn in a normal economic fashion, if you had a living wage or if you had a higher minimum wage, things of that sort. And then one of the fun parts that I really enjoy analyzing is the environmental conditions. One of the things that I learned just the other week was that the greenscape of Sacramento actually matches the red line districts. So the higher density of trees and green spaces were on the white affluent communities of Historic Pass, but still kind of exclusively denied to poorer communities and those that are traditionally represented by Black and brown communities. So, and this reflects the history of redlining, as I mentioned. And then green spaces affect physical and mental health, as having natural spaces to exercise, live, and play with better air quality as well. So there's a lot of different factors, and they all play into how they correlate, how they interconnect, And that's where we're going to start with social determinants of health. Oh, healthcare. So this one's pretty easy, and we're just going to kind of breeze by it. This is a no-brainer. So health and healthcare is a social determinant. So you can look at how you can access the care, how you have health literacy, and access to primary care. This comes from language and literacy, health literacy, to be able to say, oh, I'm aware of what preventative care I need. I can afford the preventative care that I need, and it's right in my neighborhood. And that's not exactly true for a lot of low-income communities. And I think we can jump into chronic stress, how it's related.
All right, guys. So before we move on, I'd like to propose that poverty and discrimination are the two most important social determinants of health. Some minority families have been trapped in cycles of poverty because of the historical and institutional discrimination. And in our current economy, it is hard to be poor. We mentioned it earlier that poverty is economically stressful, and furthermore, discrimination is socially stressful. We will look at chronic stress in adults and adverse childhood experiences, which create toxic stress in a youth perspective. First, we want you to simplify physiological responses as being stress or enjoyment. For example, when a piece of paper puts extreme and precise stress on your skin, it breaks and you get a paper cut. When you exert stress on a stick, it breaks. Similarly, mental responses that are stressful have proven negative effects if it is chronic or toxic and then overwhelming. So we're going to talk about chronic stress. So short-lived feelings of stress are regularly part of daily living. When these feelings become chronic or long-lasting, they can severely impact your overall health and well-being. The physical effects of stress usually do not last long. Some people find themselves in a nearly constant state of heightened alertness. This is chronic stress. Some potential causes of chronic stress include high-pressure jobs, financial difficulties, and challenging relationships. Chronic stress puts pressure on the body for an extended period, then can cause a range of symptoms and increase the risk of developing certain illnesses. So poverty is financially difficult. Families with an incarcerated parent, child, or siblings are challenging relationships. Being discriminated against because challenging relationships constantly, think about living in deep poverty. Wouldn't you be stressed out about where to sleep and what to do and what and when to eat? How to feed your kids? Would you use substances to forget about all of life's stressors? So signs and symptoms. So the type of severity of symptoms vary considerably from person to person. So signs and symptoms of chronic stress can include irritability, which can be extreme, fatigue, headaches, difficulty concentrating or an inability to do so, rapid and disorganized thoughts, difficulty sleeping, digestive problems, changes in appetite, feeling helpless, a perceived loss of control, low self-esteem, loss of sexual desire, nervousness, frequent infections or illnesses. So the bold signs and symptoms sound familiar to mental illness. And honestly, I feel that I could bold them all, but for now, we'll just go ahead and move on. So consequences. So over long periods, chronic stress can contribute to the development of a range of physical and mental disorders, including heart disease, high blood pressure, diabetes, obesity, a weakened immune system, sexual dysfunction, gastrointestinal disorders, skin irritation, respiratory infections, autoimmune diseases, insomnia, burnout, depression, anxiety disorders, post-traumatic stress disorder, and schizophrenia. So the consequences of long periods of chronic stress are both physical and mental. So we're going to talk a little bit about adverse childhood experiences, also known as ACEs. So childhood was a long time ago for many of us, not me, but for many of you, no, just kidding. But try to remember how you felt your parents' emotions when you were a child. It might have been stressful for them, and then you felt it too. The experience of stress cannot be isolated to adults. So ACEs are specific experiences of trauma and toxic stress in childhood and how they impact you over a lifetime. Toxic stress is more related to abuse or neglect with children. Neglected from a parent who has to work 2 jobs to keep the lights on can be unintentionally toxic. And chronic stress is more present with adults struggling to be responsible adults and parents. So your adverse childhood experiences have a tremendous impact on future violence, victimization, and perpetration, and lifelong health and opportunity. So adverse childhood experiences, or ACEs, are potentially traumatic events that occur in childhood, so from 0 to 17 years of age. And some examples are those of us who have experienced violence or abuse, been witnesses to violence in the home or your community, or if you've had a family member attempt or die by suicide. So when we get to part 4 about health disparities, you will see that long-term effects of ACEs mostly impact communities with fewer resources. So ACEs also included are aspects of childhood's environment that can undermine their sense of safety, stability, and bonding, such as growing up in a household with substance misuse or use, mental health problems, instability due to parental separation, or household members being in jail or prison. And ACEs are also linked to chronic health problems and mental illness, as well as substance misuse in adulthood. So your ACEs can also negatively impact education and job opportunities. So types of ACEs. So the ACEs screening is a survey where people report which and how many adverse childhood experiences they have had before the age of 17. An ACE score is a tally of different types of abuse, neglect, and other hallmarks of a rough childhood. According to the Adverse Childhood Experience Study, the rougher your childhood, the higher your score is likely to be, and the higher your risk for later health problems. And an example is for the LGBTQ community, adult health disparities are related to childhoods in unaccepting families or unaccepting communities that can often be abusive or neglectful. Positive experiences unaccounted for in your childhood build resiliency and ways to cope with ACEs. Some people with high ACE scores do really well because of positive experiences and resources that help their resiliency. So how big is the problem? So ACEs are very common. About 61% of adults surveyed across 25 states reported they had experienced at least one type of ACE, and nearly 1 in 6 reported they had experienced 4 or more types of ACEs. Preventing ACEs could potentially reduce a large number of health conditions. So, for example, up to 1.9 million cases of heart disease and 21 million cases of depression could have been potentially avoided by preventing ACEs. Some children are at greater risk than others. So women and several racial and ethnic minority groups were at greater risk for having experienced 4 or more types of ACEs. And ACEs are costly. The economic and social costs to families, communities, and society totals hundreds of billions of dollars every year. So ACEs lead to the higher rates of injury, mental health conditions, maternal mental health or maternal health complications, infectious disease, chronic disease, risky behaviors, and lack of opportunities. So this is another but different pyramid, not the historical trauma, social conditions, and local context build into adverse childhood experiences. So we want you to note that, not that. Sorry, guys. Those are social determinants of health, and they have lasting consequences over a lifetime. So the strategies to prevent ACEs from the Center of Disease Control are to enhance the social determinants of health for better outcomes. And I'm not going to go through each of these bullet points just because of time. How are we doing on time?
Fine. We're good.
So want to have a little time for some Q&A, but you can read all of these at your leisure, and I'm going to pass it back over to Noah.
So let's be a bit more specific about who we're talking about. Again, we're not talking in absolutes. We're trying not to stereotype that all minority people are poor, but many are disadvantaged because of historical and institutional policies that created the world that we live in today. This is known as structural or institutional racism, but there are no absolutes. All the data presented here relates to racial inequalities because there's not as much data on religious or sexual orientation discrimination. However, we do want to note that the LGBTQ community is at higher risk of mental health disparities as well because of history of discrimination, ACEs, and lack of social support as well. So we're going to jump in first to economic disparities to show the differences between racial populations and income and wealth inequality. The first image on the left is income inequality in California. The right is wealth inequality in the United States. So there are racial economic disparities in both income and wealth. Income is how much you make annually. Wealth is the value of your assets and investments. In California, over 50% of Latinos and 36% of Black and African Americans are near the federal poverty line, while on the, looks like the fifth bar down is 18% of whites are at or near the federal poverty line. Nationally, the wealth inequality is even more extreme. White families have an average of $171,000 in wealth, while Black and Latinos average less than $21,000. On average, white families have about 40% more wealth than all non-white demographic groups combined. This correlates most directly with the redlining policy that I mentioned previously that allowed more white families to purchase houses and accumulate wealth through the generations. Again, looking at economic disparities before we get to health disparities, we look at education inequality and housing inequality, two of the social determinants of health. Despite attaining the same degrees, Black and Latinos earn less than white individuals. This could be partially driven by job choice. For example, the gender pay gap is partially driven by women choosing jobs that pay less on average, those that are more connected to social or childcare or those things rather than, say, the financial sector that's heavily produced by men. But there are still biases unaccounted for and barriers to entry into those fields. For example, engineering is overwhelmingly a male-dominated industry, but and that's also partially because prerequisites or those are considered classes that are heavily of interest to men in general, and there's a little bit of bias in that as well. So nearly, and when we look at housing, nearly 70% of Californians with unaffordable housing costs are people of color. And again, with the historical and institutional racism, the people of color are still more likely to be renters rather than homeowners as well. And when we look This is important because we want to look at economic mobility. Unfortunately, it appears to be fading as a trend. Economic mobility is the American dream. You can make it if you work hard, right? So, however, this graph from the Federal Reserve Bank in San Francisco shows more Americans who start poor stay poor, and that's with households less than $25,000 annually, which is less than minimum wage here. And those who start rich stay rich, and that's households over $125,000. In a study that came out in 2017, Black Americans experienced dramatically lower upward mobility than white Americans do, a difference that appears to be driven largely by significant economic disadvantages among Black men. These conclusions came from a groundbreaking study that combined Census Bureau data on race with IRS tax returns, which allowed economists to track individuals' earnings over many years and tier them to their parents' earnings. The first paper to combine census, race data, and tax records was released by the Census Bureau's Maggie Jones and Sonia Porter on UCLA's Randall's Atkey in 2017. So all the economic factors that we just mentioned and the social determinants of health that were built into those factors also lead towards physical health disparities and mental health disparities in both chronic and acute conditions. You can see on the left, more people of color suffer from chronic conditions, and on the right, an acute condition, specifically maternal mortality, is at greater severity. So chronic conditions include asthma related to air quality, diabetes and heart disease, and obesity related to poor nutrition and exercise. So green spaces and food deserts and food access and health access. And the maternal mortality rate of Black women is nearly 4 times higher than white women. Still fairly undecided as far as why, or at least I didn't look into that. So we'll hear more about that in the coming years. And when we look at mental health disparities, I pulled 2 specific slides from California Healthcare Foundation in their 2018 almanac on mental health. The chronic stress of poverty increases the likelihood of serious mental illness. And this directly correlates to the overrepresentation of people of color, with mental illness and those who experience deep poverty and homelessness. We're not saying all poor people have mental illness, but there are higher rates of serious mental illness with poor people. Remember, more positive experiences and more resources counteract the effects of chronic stress or toxic stress in childhood. On a side note, related to these 2 graphs, I wanted to mention that 2 studies came out this month that stated if minimum wage went up, suicides would go down. Additionally, the most accurate predictor of higher veteran suicide rates in California counties was a higher unemployment rate in those counties. This illustrates that poverty and employment as very important social determinants of health. One more thing that I wanted to add was that's not shown on this slide is that the average lifespan of mental health consumers is significantly shorter because of comorbidity of chronic conditions and behavioral health issues. Clients and consumers have the opportunity to live fuller lives if chronic conditions are cared for with affordable preventative and persistent care at the same rates as affluent communities. Not only does this skew average lifespans of consumers, but also people of color as a whole demographic group. So at the beginning, I did mention that there's social determinants of health and can either be influenced to create better prosperity or degrade health and prosperity. And around the world, there are things called blue zones. There's just a few communities that are recognized: Okinawa, Sardinia, Loma Linda in California, one in Costa Rica, and Greece. And these are known as blue zones that have a lot of family support, social engagement, clean air, good nutrition, and exercise. And they have positively enhanced the social determinants of health to create longer lifespans in their communities. And they also traditionally have less racial tension in their communities. And so that was as much as we could fit into 40 minutes. And so we learned about how important equity and true economic mobility are to create healthier societies and reduce societal costs, and to recoup economic gains that could be earned if more people were less poor or discriminated against and healthier. One resource that I want to add, and that we included in both the reference page at the end, is a podcast from Brookings Institute that accounts for $156 billion of wealth missing from the US economy because of Black-owned property value loss, just because of lower valued housing in predominantly Black neighborhoods. So again, think about the ripple effect about how much $156 billion of economic resources could have created in gains in education, employment, innovation, housing, health, crime, and taxes for Black Americans. And for those curious, and then also Colusa County, I wanted to note, is one of the first California counties to address social determinants of health. And they put out an innovation plan in 2017 that addresses the social determinants of rural health. So that's what we went over today.
All right, so now we're gonna go ahead and unmute everybody. Whoopsie, sorry about that, got trigger happy. Let me see here. And if it gets too hard to hear, we can mute and then you can raise your hand. But are there any questions or discussion items that folks would like to touch on?
This is Carol West.
Hi, Carol.
I'm wondering, hi there. I'm wondering if there is, if you've come across any of the work that's been done with the community health workers, and what the crossover is between community health workers and peer support specialists in terms of addressing social determinants of health.
So a lot of the data that I looked at was at a state level, not necessarily down to a community level, but having done one of the e-learning programs on recovery and peer support in general, they do work on non-clinical or non-medical issues that are related to health, that include employment and social networking and community integration and things of that sort, that do contribute to the way that mental health care is provided in California to help alleviate some of the social determinants of health, or those acute factors of isolation in mental health. Does that help?
Yes, thank you.
Yeah.
Hi, this is Amparo.
Hi, Amparo.
I wanted to just point out, like, I know I wrote it in the text box, but a lot of the, I think, disparities that are happening in lower income communities have to do with, well, basically capitalism and the fact that, like, you know, we kind of live in an individualistic society where, you know, it used to be, oh, the American dream, you know, work as hard, but now the people that are, you know, CEOs of companies, they're progressing, they're becoming richer at the expense of their employees. Like, they're not giving them the benefits they deserve. They're doing away with 401ks, they're doing away with pensions, they're doing away with unions, where it's just resulting in, you know, like an average employee that is, you know, supposed to be making at least a livable wage, not something that anybody can live on. like, that's saying that everybody, well, not everybody, but so many people are a paycheck away from being homeless, has to do a lot with how our society has allowed this increased great rate of growth for the really high income people, and not met with the middle class keeping up with the cost of living.
I would agree with you 100%, but there's also what we need to recognize is that is a form of discrimination. A lot of the conversation that we do here is about haves and have-nots, or makers and takers, and this bifurcation of society allows for people to discriminate from themselves and others, or how they perceive the outside world. And it relates to what it means to try to identify with people in their community and people who are different from them, which is that whole idea of why discrimination maybe historically was about race and sexuality, or religious identity, or however it was, but now could almost be morphed into socioeconomic terms in that type of discrimination that still greatly impacts communities of color and low-income individuals.
Hello, can you hear me?
Yes, we can.
Okay, this is Laurel Ben Hamida, and
Hi,
I
Laurel.
just wanted to say this is a really wonderful topic. I am on the board at Muslim American Society Social Services Foundation, one of the first social service organizations to work in the Muslim community.
Yeah.
We're based in Sacramento. We actually recently had a training for our peer support and counselor people, some of whom have been trained by you, from an African American woman who runs a foster care agency in the area. And so I think this is a great topic. What I think it is hard to find data about and information about, good data anyway, is the problems of refugees and immigrants. And that can cross color lines. We have a lot of Ukrainians and Russians and people from Bosnia in Sacramento who have had terrible ACEs and intergenerational trauma. That's one thing I want to mention. And then we have the Syrian and Iraqi and Afghani refugees, and those from other places in the world that have come over the decades. And they have the past trauma that they've gone through. They have the present trauma that's going on with the people that they've left behind in their home countries, their friends and relatives. And they have the current trauma of what's going on in terms of the policy of the current US administration. And I don't think I need to go into detail, but you can imagine how it affects people. When you see a woman walking with a scarf because she doesn't have other transportation, think about how she feels and how vulnerable she feels. So I just wanted to bring that up, not just because it works well with your topic, it's part of your topic. Thank you very much.
Yeah, thank you for adding that. One of the things that I was noting while you were talking was that many of the refugee spaces that you were mentioning were in conflict areas, or historical or present. And I would say that war is a huge social determinants of health as far as trauma and how it affects childhood or adulthood or any type of lifestyle. And I think that it really needs to be important when we look at a global scale, for sure.
Pam, Weston, I see you have your hand up. Go ahead.
Hi, in dealing with you presenting on color lines, it's a big issue, Noah. You have to deal with national standards, and with my family, we're multicultural. And in dealing with even that, like in Monterey County, I've asked them to do class standards. There's no ethnic service managers. Ethnicity and race deal with that problem in the first place. It's not data driven. It's not culturally specific. And in districts, when we're dealing with the Mental Health Service Act, even with our with the trainer for providers, she wants to do labs where they speak about things instead of how that they live with things. With my granddaughter, she was put into state hospitals in Alabama. I was not able to see her as her grandmother. When they were dealing with adoption, they were talking about her name itself. So I would appreciate a follow-up with multiculturalism versus race. And when you deal with black and white, and it's the problem when that you deal with funding, when you deal with commissions, there is no representation for any of what that we live with and how that we are. And there's no access because you're dealing with black and white data, but it doesn't show health determinants and harm reduction for even things like what you presented today. And the funding has been because of the time of consciousness, where that people would come together and they would even call Spanish white. And so we have a problem, and I hope that you will look at national standards versus versus state standards, and because to continue in that way, that's why we haven't been able to have enhancement. And we have one little program called the Village Project, but they haven't been able to have access to any funding. And like you heard me speak at the assembly, we have a cultural relevancy action plan, and we have to focus on intersections because with diversity and inclusion, you talk about LGBTQ, and our LGBTQ got funded, and you talk about biracial and bicultural, but you don't talk about culturally specific, district specific. And with district specific, where there was even Fort Ord, a predominant cultural center of multiculturalism, and now they're just saying Mexican. Even that's not accurate. There's Oaxaca and Triqui and Guatemalan and El Salvadorian. So we don't need black and white state standards. If we're talking about social determinants, we need to talk about multiculturalism.
Yeah.
And the mental health commission even challenged Dana and said, where's your activities? Because we've done equity work, we've done governing for racial equity, but you have to use national standards, because when you deal with people of culture, not color, then people are more than from Africa. They're from Panamanian and Cuba, and they're multiculturalism like my family is. And so we haven't covered that in the webinar in what we could ask for with the mental health oversight and mental health expenditure plan, because they think that they can do what they've always done, but there's no expenditure that addresses a historic trauma of anybody who has no representation or has been unserved, except for I pushed them with what you gave me, Noah, and they first time
Yeah,
did.
I'm gonna go ahead, and we're almost out of time, and we have two other folks that have their hands up, but I do want to say that this is I really appreciate your feedback, and I'd love to talk with you more offline as well.
Okay.
I would like to call on Douglas or Doug. Hi, are you still there? You have your hand up? All right, Doug's not responding, so I'm going to move on to Amparo. Did you?
Oh, no, I think I forgot to put my hand down.
Oh, okay. So was there anybody else? We have time for one more, and then we're out of time, but I wanted to give them an opportunity. Does anybody else have anything they'd like to add before we close? All right. Well, I do want to let you know I had a question here asking about if this